the extremity brain to optic nerve and transmit signals back and forth. And so over time with that attack, we get injury to that nerve or reduced signal kind of going up and down it. How common is MOGAD? So every year, 1.6 to 4.8 per million adults are diagnosed with MOGAD. This number is likely going to increase the more and more we learn about the condition, the more we know to test patients for it. So this number is going to grow, and the number is actually probably higher because what you'll see when I talk later is that sometimes patients convert to antibody negative. And so when I meet patients who had events 10 years ago, I can check their antibody level now and it may be negative. And so they may fall into this undifferentiated category, but in reality, it could also be MOG, and we just don't know. Typically, average age of onset is around 30, although there's a large pediatric population, and also we see patients present well beyond that as well. And so far, we're seeing kind of an equal occurrence between men and women, which is different than some of the other conditions that I treat, like MS, where we tend to see really a predominance of women impacted. And so far, we're not seeing a racial preference, but really, because this has only recently become a distinct entity, these things may change as we learn more and more about the disease. And so TBD on where this slide goes in 10 years as we learn and do more research about the disease. And so what are the symptoms of MOGAD attacks? And so I'm going to briefly go through these. So it's very dependent on where is attacked. So in the optic nerve, we get optic neuritis. If the spinal cord is attacked, we get transverse myelitis. If the brain is attacked, we can get encephalitis and seizures, or we can get something called ATEM, which I'll explain a little bit more. So it's very dependent on that. And also it can be multi location. So you can have two of these things at once within an attack, just depending on the presentation. And so optic neuritis, for those of you who don't know, is inflammation of the optic nerve. Typically, patients are going to report eye pain to start, and typically this pain is most notable with like side-to-side movement or up and down movement. And then this will progress to blurry vision, or sometimes complete vision loss, depending on the patient, and tends to be one or both sides. One of the unique things about MOG that differentiates it from my MS patients is that a lot of times it's bilateral, meaning both sides, where most of my MS patients generally come in with one side impacted at a time. And so that's always a clue to me as well. If I'm meeting a patient and both of their eyes have been involved in an attack, that I should look for MOG. The next is transverse myelitis, which again is from involvement of the spinal cord. And this can present in a lot of different ways, depending on where in the spinal cord is attacked. And so patients can have weakness in an arm or leg. They can have walking difficulty. You can have muscle tightness. The other term we use for this is spasticity. Sometimes patients will have involuntary movements of extremities depending on where and what's involved in their spinal cord. It can also sometimes be sensory symptoms, and it can be positive symptoms, meaning that it's a symptom of feeling something, so tingling, burning, or it can be a negative sensory symptom where you lose sensation at a level or below. Patients also typically will have some sort of bowel or bladder symptom along with this. The next is encephalitis, and these next ones are a lot rarer than transverse myelitis and optic neuritis. But this can present a lot of different ways. Patients can have headaches, they can have confusion, they can have speech changes, they can have behavioral changes, they can sometimes have seizures related to this, and sometimes even fevers. Again, this one is not as common, but we found it quite a few times here at our center when we didn't think we were going to find it. And so it does happen sometimes. And then there's acute disseminated encephalomyelitis, which is ATEM. This is mostly seen in children. And what you'll notice is that the description is very similar to what we see in encephalitis, but very, very more common in the pediatric population. And so again, it's very dependent on where is involved. And one thing to realize is that patients can also experience symptoms outside of an attack. So outside of that original presentation to the hospital, treatment, months, years down the road, you can still have symptoms. And a lot of times it's related to that underlying damage that's there, depending on how much a patient recovers. And that's kind of a spectrum as well. We do know that most MOG patients tend to respond better than some of the conditions that we treat in terms of recovery-wise, but it's very patient dependent. In terms of chronic symptoms, and so, like I said, outside of an attack, those big things, patients will report, continual kind of vision changes, not as drastic in terms of not the pain and sudden onset, but they can have residual blurry vision. One thing I often hear is, trouble driving at night, and then sometimes like a depth perception issue, so trouble like with stairs or where we're trying to change a level. Patients will notice issues there. Bladder and bowel symptoms are common after the fact, specifically after a transverse myelitis event. Sometimes patients, this will be the only thing left in terms of symptoms, where they'll have a full recovery in terms of motor or strength, but they'll still have some bowel or bladder symptoms. They can have sexual dysfunction. There can be pain and spasms. There can be those sensory symptoms that kind of come and go. I find that those are sometimes the most frustrating for patients because they can change over time, which can make it very confusing. And then often patients will get mood changes, so depression, anxiety, and it's a little less clear if that's a direct result of MOG or just more so what's going on, the bigger picture, the coping with this new normal. And then fatigue is also pretty prominent in this patient population. I will say it's less common than what I see in my MS patients, but it certainly happens. And so how do we diagnose this? And so generally the first thing that's going to happen when someone comes in the door, at least at our center, is an MRI. And then we're going to go on to do these other testing. And the big one now is the MOG antibody testing. And a lot of times we don't just send one lab at a time. So when you come into the hospital, it's MOG plus all of these other tests that we do, maybe a spinal tap, just depending on what we're thinking. Because again, we don't get one and then negative and then do the next one. We tend to do it all at the beginning. Sometimes we do optical coherence tomography, which stands for OCT. It's this really fancy picture of the optic nerve, which we can see kind of a window into the brain in a sense where you can actually measure myelin. So it's really, really cool and really, really helpful in our patients who've had optic neuritis or visual symptoms. And then sometimes we'll do spinal fluid, just depending on the case. See. One thing to note is that MOG antibody levels can fluctuate, and this is a question I get a lot from my MOG patients. And so patients will be positive, and then it seroconvert. So we use that term to say that they transition from a positive antibody to a negative antibody level. And so this can fluctuate over time. And we don't fully know what this means yet. And this is often what I tell my patients is I'm checking this and banking this knowledge for in the future, because I do think as research goes on, we will have a much better understanding of what a persistently positive antibody means, or an antibody that goes from positive to negative, but back to positive. Because right now it's not a reliable marker for, oh, someone's going to have another attack. And so I bank my patient labs is what I tell them, and generally check it at least once a year, sometimes every 6 months, depending on the patient. But I tell them not to panic because the antibody itself doesn't necessarily indicate, if it's still positive, that they're going to have another attack. And so just beware. I think there's a lot more to come in this realm as well, because there's a lot of work being done on antibody levels and what it means. So how do we treat this? And so there's two phases of this. So there's acute treatment and there's preventative treatment, depending on kind of where you fall. Acute treatments, the mainstay is steroids, typically IV steroids, but not always. And then we're going to give you a pretty hefty dose in the hospital. In general, with adult patients, we give you like 1,000 milligrams of Solumedrol, which is a high dose if you think about what patients get for like run-of-the-mill sinus infections and things like that, but it works really well. And depending on response to that, we may escalate to other therapies. So one is plasma exchange, or PLEX is what we commonly refer to it as. And in this, we're essentially kind of washing the blood of those inflammatory components. Or sometimes we'll do IVIG, intravenous immunoglobulin, which is another way to kind of reduce the inflammation that's ongoing. And so at our center, we tend to do steroids and jump to these other two if a patient's not responding. Although I have some patients who I know, hey, if they have a relapse, they don't respond well to steroids, they respond well to X, then sometimes I'll just jump straight to that depending on the patient. But for the most part, most patients with MOGAD do really well with steroids, but there are exceptions there where patients need escalation. And then in terms of preventative treatment, so one thing to note is that there's no FDA approved treatment at the moment, although there's clinical trials ongoing. And the four here are what are typically used. So mycophenolate mofetil is one, rituximab is one, azathioprine is one, and IVIG is one. And these all work to, over time, kind of control or reduce or suppress the immune system that's confused. And so, depending on where you're seeing, most places have a preference, or it can even be provider specific. I know in our own practice that we all kind of have our own way of doing it, and one way is not necessarily better than the other. And so I always tell my patients, because they frequently tell me, well, hey, I see Dr. X and they put me on this, they put my friend on this. Why are you putting me on this? And so it's just good to know that there's multiple options and everybody kind of does it differently, but these are our typical mainstays if we need preventative treatment, which brings me kind of to the next point is, what are the two types of MOGAD? Who needs treatment? And so we have what we call monophasic disease and relapsing disease. And so in monophasic disease, this is when a patient has a single attack of one of those things that I previously mentioned. And again, it can be multiple of those things. So a patient can have optic neuritis and transverse myelitis. And these are treated with those acute therapies that I mentioned. But one of the things that currently most places do is we don't generally put patients who have monophasic disease on a long-term preventative treatment because we know a large proportion of patients won't go on to have another attack, at least with the information we have now. And so these patients typically, first attack, most of the time they're not being put on something long term. They may be on steroids for an extended amount of time as they leave that hospital setting, but I'm not necessarily putting them on a medication that they're going to take for years and years and years after that. And then, but that's very distinct from the relapsing phenotype. And so this is when a patient has more than one attack, and generally we want to see it separated in time, so not within a short window of that initial event. And it may be different than the first attack. So just because the patient comes in with transverse myelitis for their first attack doesn't mean that every subsequent attack is going to be transverse myelitis. Actually, it's more common to come back in with a bilateral optic neuritis if you're going to have a second attack. Not always, but that's what's the most common, at least in the literature now. And typically these patients do require long-term preventative treatment. Those agents that I had previously discussed, just depending on what you and your care team decide. We don't know how long though. And again, I think that's something that will get over time as we, learn more and more. But for now, these patients do require being on something to kind of go on the defense and prevent another attack. And so something I'm commonly asked is, what is a relapse? Because we use lots of different terms to call for a relapse: attack, flare. But one thing I always tell my patients is that it's new or recurrent old symptoms when we have what we consider objective evidence of new disease activity. And a lot of times, no trigger. And so if a patient called me with symptoms and it's symptoms they've had in the past, I'm not usually as concerned because a lot of times we can identify a trigger. They have a fever. They have an infection. They, didn't sleep well. They're under a high amount of stress at work. And so it's very common when there's a stress on the system for old symptoms to kind of come back. And so what I generally tell my patients in those scenarios is, let's watch it over the next 24 hours and see how it evolves. If it, gets better as we, treat or manage that underlying issue that we've identified, then very low concern. If that old symptom is evolving though, progressing, not going away as we remove that trigger, then we get more concerned and we start get the ball rolling in terms of looking for relapse. And a lot of times I like to talk about this because I think it can be confusing. So a lot of times we call these things pseudo relapses, a pseudo flare, or a pseudo exacerbation. And a lot of times my patients look at me like I'm crazy. And so I always like to say this when I meet new patients because I use these terms a lot and it can be very confusing for what does that mean. And so essentially, like I said, it's just kind of recurrent of old stuff where we're not gonna, if we looked, we're not gonna see evidence of new damage going on. And then this is from the MOG Momentum series, and I thought it was a really good kind of way to walk through, how do I know if I'm having a relapse? And it was done beautifully. So I was like, I'm just going to copy and paste this in here because I think it helps because it's everything I just said. So what is more likely to be a pseudo relapse? Is it an old symptom? So if it's not a new symptom and an old symptom, it's more likely to be that. And then as you see what changes is new symptom or old symptom not getting worse, and then time. And so like I said, generally old symptoms that we're not seeing progress beyond 24 hours, I'm not concerned. If it's an old symptom that's going on more than 24 hours, I can't find a trigger, then I'm going to start getting the ball rolling. And if it's a new symptom, I'm very concerned. And that, so this is on the website. I think this is a great reference for patients to look at whenever they're having issues, to kind of walk through this. And also, it's never wrong to call your care team. I always try to empower my patients that if you're concerned, call me. I would rather find out about it then than 6 months down the road, because I can do something then. I can't do something necessarily 6 months down the road. And so have that power to contact our care team. And so that's kind of where I'm going to end on the broad overview, because again, I think it helps the discussion. And I think maybe stopping the recording, I think we had talked about.